Okay.
Yes, yes, sir, you can continue with this only.
Okay.
Yes, yes, sir.
So maybe during the question answer session, we can you can connect from phone.
Yeah, I
Currently,
can.
you can.
Yeah. Okay. Go ahead, please.
Yes, Dr. Jain, please.
So good evening, everyone, and we welcome you all today for this Learn from the Masters session 9. And we have with us a very renowned vitreoretinal surgeon, very senior vitreoretinal surgeon, Dr. Dinesh Talwar, sir. I would like to ask Dr. Shishir Singh, who is a senior vitreoretinal surgeon with ASGI hospitals for the last 7 to 8 years. He's also the medical director of ASGI Hospital Noida and provides his vitreoretinal services at Noida and Patna. So, Dr. Shishir, can you please introduce Dinesh Talwar, sir, as well as our panelists for today?
Yeah. Good evening, everyone. I welcome everyone on behalf of ASGI Hospital on this auspicious day of the Chhat Mahaparv being celebrated here in Bihar, a 4-day long festival. So on this auspicious day, I welcome you all for this meet today evening. Am I audible? Yes.
Yes, yes.
Hello.
Yes.
Yeah. So the speaker for the evening today is Dr. Dinesh Talwar, sir. Sir needs no introduction. I'm feeling honored to be introducing sir for the second time. If sir might remember, we had a Bihar Ophthalmological Society KRC back in 2022, where it was an afternoon program by Dr. Nagendra Prasad. Sir was the main speaker there, and we had a very lucid talk by Dinesh Talwar, sir, back then also. Sir is a renowned vitreoretinal surgeon, and right now he is the senior consultant at Center for Sight, New Delhi. Sir has over 38 years of experience. Sir is the editor of multiple journals. Sir has multiple publications and articles to his name in national and international journals and multiple chapters in various books. Sir is the recipient of this echo. Sir is a recipient of various awards. Hello. Is there a disturbance in the voice?
Yeah, please go ahead. I think Talwar
Yeah.
sir's 2 laptops were on.
Okay. So, sir is a recipient of various awards of national and international repute. The further panelists for the evening today are Dr. Mahesh Shanmugam, sir. Dr. Mahesh Shanmugam, sir, is the head VR services and ocular oncology at Sankara Eye Hospitals. Sir is the co-founder of retnetindia.com, of which all of us are a part, and garner a lot of knowledge from the group. Sir was the convener scientific committee of VRSI back in 2022. Sir has numerous scientific publications in national and international peer-reviewed journals. Sir is also a recipient of multiple awards of national and international repute. The next panelist for the evening today is Dr. Dhanashree Ratra, ma'am. Ma'am is a senior consultant at Shankar Netralaya, Chennai, with a vast experience of over 26 years. Ma'am is the section editor of IGO, Frontiers in Ophthalmology. Ma'am was the past editor of APAO back, and she has hundreds of publications in peer-reviewed publications. Ma'am is also having various chapters in various of our ophthalmology textbooks. She's also a recipient of multiple awards of national and international repute, including her first, the Best Lady Fellow Award back in 1997. The next panelist today we have Dr. Ahmed Salam, sir, who is an associate professor at the Harvey and Bernice Jones Eye Institute. Sir is a uveitis and medical retina fellow and also has 2 other fellowships from the UK. Sir is an active member of the American Academy of Ophthalmology and also is a member of the European and American Retina Institutes. Sir had multiple, over 70 peer-reviewed scientific manuscripts. The next speaker on our panel the evening is Dr. Soumil Sheth, sir, who is the medical director at Envision Eye Hospital, Mumbai. So he's also a part of our organization ASD now for some time now. Sir is an MS from the prestigious Sion Hospital in Mumbai and a fellow from the LV Prasad, Hyderabad. Sir is also an ICO Retina fellow. Sir has instructed and trained postgraduate ophthalmology students and retina residents at Sydney Eye Hospital, Australia. Sir also has numerous scientific publications in international peer-reviewed journals and also holds gold medalist, also is a gold medalist from his MBBS, DOMS, and FCPS in Mumbai. Sir is a titled international scholar with ranking among top 6 in the world, ICO Ophthalmology Service UK. The next panelist for the evening is Dr. Mudit Tyagi, sir, who is the head of Srimati Kanuri Santhamma Center for VR Diseases with over 15 years of experience. Sir is a recipient of the Achievement Award from the prestigious ASRS. Sir has 80 scientific publications, over 80 scientific publications in international journals. Sir has also developed an innovative surgical technique for RD and macular hole, not requiring strict post-operative prone positioning. So this was the list of our very esteemed panelists for the evening. And I would like to welcome Dr. Dinesh Talwar, sir, for his talk for the webinar today evening. Over to you, Dr. Talwar, sir.
Shir, I think it's very obvious that we have a very, very vast panel of people over here today. So this is not a talk. This is an interaction, and basically, I think this is an opportunity to get everybody's viewpoints on different aspects of this fairly complex topic. And I just saw that my video is now on even in this. So it's coming from the other side. So I've got both my computers on. One has the video and the other has the audio. I think let's start. We've spent a lot of time on getting set. So I am starting my screen sharing. For a long time now, I believe that we need to think of patients of high myopia with rhegmatogenous detachment not as one category, but wanted to highlight how I treat my patients differently in different situations. And I mean, I would really welcome the interactions we have, which tell us how the other experts over here handle them differently. Yeah, so before we go further, there's some anatomic facts of relevance which I'd like to talk about. We all know about the fact that you have an increase in the axial length. But this axial length then results in a posterior staphyloma, which is not the entire eyeball going back increasing at the back, but a small part of it. A part of it goes much deeper than the usual depth. In addition to that, you also have vitreocysis, which results in a pseudo posterior vitreous detachment. So you have what looks like a posterior detachment, and then you find there's another layer of vitreous, sometimes more than one layer of vitreous also present. Be careful, especially in terms of buckling. Have this posterior staphyloma, and then if the retina detaches, you've really got a relative shortening of internal limiting. So so one of the most important things for us then is to keep in mind the fact that the ILM is extremely elastic, and this causes traction. Now, just to clarify one thing, everyone thinks in terms of elastic as something that you can pull apart. That's not elastic, that is plastic. Elasticity means the tendency of a material to go back to its normal position. So iron is more elastic in that sense than a rubber band. So basically, what happens is that because of this, the retina cannot move. It loses its ability to follow the wall of the eye, and that's why the ILM is so important for us. So its removal helps us to permit the retina to fall back onto the walls of a posterior staphyloma. If there is a macular hole, it allows the walls to oppose each other, permits a retinoschisis to settle down, and will also obviously prevent a recurrent ERM formation. Now, what are the things which you keep in mind when you're doing a surgery for a high myopia with retinal detachment? What are the issues that come to my mind? The first thing that comes to my mind is the age of the patient. If it's a younger patient, clear lens, that's the situation where I prefer to do a scleral buckling. And of course, degree of myopia makes a difference to how difficult it will be to do the surgery. The location of the breaks. Now, this is an extremely important thing. And say how do you see it? Basically, you're trying to determine its direct distance from the aura. So the tip I use for this is that because if it's a equatorial or anterior to the equator, the breaks are there, I would prefer buckling. And how do I assess it? I will indent it through the lid. And if when I indent through the lid, preoperatively, I find that I can indent just posterior to the break, I know that this particular detachment is buckleable. Another way, the important thing is don't go in relationship to the equator, because the equator can be at a varying distance from the aura. So the other way is indent from the aura, see the aura, keep going more and more posteriorly, and see how much was the distance between the aura and the point where the break became visible. If it's close, you know that this is easily buckleable. If it turns out that the distance is coming too big, it means that you're going to have a problem doing a buckling in this procedure. Now, operatively, before starting, if you indent in through this conjunctiva also, transconjunctivally, and if you find that you're somewhere around 15 millimeters or so from the limbus, your break, your sutures will be around 18 to 20 millimeters, the posterior suture, and this is easily buckleable. In today's world, I don't like to put very posterior buckles. There was a time when we used to go up to 22 millimeters behind. Today, I do not like to do this. Now, the important thing which is relevant in a high myopia, we know that one of the most important things which keeps the retina attached is the embolic factor. And the RPE pump, just to give an idea, we never realize how effective it is in a normal choroid, in a normal RPE. The rate of pumping is something like 0.3 microliter per hour per millimeter square of RPE. That translates into something like 300 microliter per hour or 5 microliter per minute of drainage. That's more than double the rate of aqueous drainage. But this efficacy is not there in high myopia. If patients who have slowed down, so you have to be careful. You want to drain much more of the SRF so that you want to make it easier for the retina to settle down. These are some of the other factors, the physical factors like the interphotoreceptor matrix. We're not going to go into this. The other important thing, and this is a factor which we need to keep in mind. People ask, how long do you need to keep silicone oil if you put it before you remove it? So, after surgical repair of a retinal detachment, the reattachment occurs promptly, even before the outer segments have regenerated and the microvillus connections have reestablished. But this adhesiveness does not return to normal till 5 to 6 weeks after the rear position otherwise in an experimentally detached retina. So if you want to do a silicone oil after a high myo in where you in a high myo, then you should wait. I'm sorry, this is not 5 to 6 months, it's 5 to 6 weeks after the initial surgery. Now we know we are basically talking about basically a tug of war between the RPE pump, the interphotoreceptor matrix, the intact retina, and on the other side vitreoretinal traction. Now let's see the basic problem for high myopia is you've got a weaker RPE pump, so less adhesiveness and more traction, and therefore more chance of failure. So this is how you have to see how to handle the traction better, because you can't do anything about it, and how to make the RPE pump work by draining more of the SRF. Now, what are the factors of significance when in a high myopia for vitreoretinal surgery? Here, the most important point is whether there is a posterior staphyloma or not. How much is the RPE atrophy in the macular area, as I've already explained. The fact that you have to look very carefully for the layers of cortical vitreous which are adherent to the retina, the vitreoschitic layers. You're going to have, in patients who have RPE atrophy, you're going to have difficulty in ILM flap visualization. And of course, you have to see how to stabilize this flap over the macular hole if that is present with the detachment, and how to complete the drainage of this SRF without dislodgement of the ILM flap. Now, what are my objectives? We all know that we are all vitreoretinal surgeons here. So you want a temporary closure of the break, which permits the removal of the SRF by the RPE pump slower or faster. You want to create your layer of adhesion between the RPE and the other 9 layers, and that's with either laser or cryo. And the options we have are 3 main ones: scleral buckling, pneumatic retinopexy, and vitreoretinal surgery. In eyes which have an RD without a posterior staphyloma, and if there are only peripheral breaks anterior to the equator, it's a phakic patient, and I can put the posterior scleral sutures around 18 to 20 millimeters from the limbus, I would prefer to do a scleral buckling. On the other hand, if I have a patient whose breaks are posterior to the equator, or it's a bullous RD or there's hypotony, I'd prefer vitreoretinal surgery, and then you need to take care of the vitreoschisses. And if there is no posterior staphyloma, you don't need an ILM peeling. And of course, if you have an eye with posterior staphyloma, this vitreoretinal surgery is not going to end with vitreoschisis removal. It also needs ILM peeling at least till the edge of the posterior staphyloma. Now, the advantages of conventional buckling for me is, well, it's mainly a intraocular procedure, but the most important thing is that in a young patient, being able to save the lens is a very big advantage. The disadvantages include risk of accidental perforation of the globe, which has become much less, significantly less, after the use of microscopes. Causes a myopic shift, and then you can have buccal related problems like buccal infection, and very rarely a CRO. And then there are the risks of SRF drainage like retinal incarceration and subretinal hemorrhage. Now, when you do the buckling, where do you want to place this buckle? For me, the important thing is you indent the posterior edge of that break and place the posterior suture 5 millimeters posterior to the posterior edge of the break. This is the safest way of doing it. Though, vitreoretinal surgery, sometimes they talk about 3 millimeters or so, but 5 is what I consider ideal for a buckling procedure. 4 is borderline. Anterior suture is placed 10 millimeters anterior to the posterior suture. So I actually measure it and put it, and this is in case of a 7 millimeter buckle, because basically you want to put it as 1.5 times the size. The suture bite is of at least 4 millimeter if you put 2 or more sutures per quadrant. and at least 8 millimeter if a single suture is being placed in the quadrant. The distance between adjacent sutures, suture bites should be 1 to 2 millimeters. So this is just to show you the correct distance, which is 1.5 times the size of the buckle. If you put it is too close, it won't indent enough, and you put too much, it just increases your posterior slope, but does not actually increase the anterior slope, which is what you want. So this is just to show you, you want the break to be on the summit or on the anterior slope. You don't want it to be on the posterior slope, which will happen if you make it a very high buckle. Basically, we use a reverse spatulated cutting needle, 40 silk, 50 proline. The suture bite should be such that the burrow of the needle is visible in the sclera at all times. The bite is tangential to the scleral surface at all times. Avoid areas of marked thinning and avoid the intrascleral path of the vortex veins, which is between 15 to 18 millimeters from the limbus. The band helps you to reduce the circumferential traction, which is important in these cases, makes the buckle more permanent, and prevents the decrease in its height over time. The usual placement is 14 to 15 millimeters from the limbus. When we used to put these buckles very posteriorly, there was a thing about making it more anterior one side and posterior. Leave all that, because I don't want to have a distorted globe in today's world of vitreoretinal surgery. The most important thing is, do not tighten the encircling band more than 20% under any circumstances, because you risk anterior segment ischemia when you do that. Ideal tightening is 15%. I'm often asked the question, how do you make sure it's 15%? And I believe everything in vitreoretinal surgery can be actually mathematically put in order. So pass the encircling band in all quadrants, mark the distance between the loose ends of the quadrant where the encircling band is to be tighten, then cut the excess amount such that the size of the loose ends is same as before. The length of the band which you cut should be around 12 millimeters. That is 15%. And that's because you know the equatorial circumference is 72 millimeters. And based on that, that's around 8 as a easy calculation. Just to show this, this is where your encircling band is there. This is where it was placed before tightening. You tighten it. Now it's gone further on both sides. Remove this excess amount from here and here and measure this. This total amount should be 12 millimeters. Can do a non-drainage if you can approximate the break to the buckle. Shallow RD, not very old SRF. So it's a great way to go ahead. On the other hand, I would prefer to do an SRF drainage in most of my patients, especially if the RD is old, but even if I find that's easier to approximate the break to the buckle that way. The conventional technique is after doing diathermy of the sclera and then making a cut in the sclera and then using a 10-0 needle to perforate or a diathermy point to perforate that. I believe that carries a higher risk of incarceration of the retina than the technique which we use, which is a modified needle drainage technique where you use a 26 gauge needle and then use this to and how do you choose the site of this this makes sure that you don't end up with medial lateral rectus muscles. Do an indirect ophthalmoscopy indentation and you can really pick up a relatively avascular area. Am I audible?
Yes, sir, you are audible. But I think the
Am I
screen.
audible?
Recording in progress.
Hello?
Hello. Yes,
No,
sir.
I
Yeah,
never.
am I audible?
I think after the step of perforation, we cannot hear you. After
Can
that
you hear me
drainage.
just now?
Yes.
Yes, sir.
We can hear you, sir, but your slides are not visible.
Now they are not visible. Should
I think you'll have to share it
let
again,
me
sir.
just, yeah. Okay, can you see them now?
Yes, sir. The
Yes.
slides are now visible. You are audible as well.
Okay. And till this point, was it okay? Were you able to hear me till this point?
I think till slide 23 we could hear when you were talking
Okay.
about the modified Prang
Yeah,
technique.
we were
That's
exactly
where we
there on
stopped
this
hearing.
slide.
Yeah.
Yeah. Okay. So I'll go ahead from there. So basically, yeah. So basically, the sequence of steps that I follow is I first pass encircling band and buckle sutures. Then I place the band and the buckle below the sutures in its position. Then I tighten the SRF, then tighten the encircling band to maintain the pressure. I make sure at no point of time during this surgery is the IOP allowed to drop, because that I believe is one of the most important reasons for a bleed to occur. Then once the buckle is giving its indentation, the pressure is maintained. That's when I cryo check under the buckle. I place the cryo probe under the buckle and cryo it. Then I tighten the scleral sutures for the buckle to the appropriate level. Then I tighten the encircling band to ensure my 15% tightening, because initially I've tightened it too much. When I end, the pressure became low, so I've tightened it more. Now I bring it back so that it's 15%, and then I complete the surgery. Now, the reason I wanted to point, when I started doing RD surgery, I was taught that, first you do cryopexy, and then you go ahead and put the band and everything. I always found it a little unusual, because I'm doing cryopexy in an area at a time when the height of the detachment is the highest, the break is most difficult to access, maximum amount of cryopexy will occur, more reaction, lot of RPE cells will be shed into the subretinal space and into the vitreous cavity. So I found that something that was not acceptable to me. And then, so down the line, I decided, let me do the SRF drainage first. But then the problem comes, if you do the SRF drainage first, the pressure will go low. So I put the band, put the buckle. These are temporary, they're just there. Now I I do the SRF drainage and remove as much. While you're doing the SRF drainage, you continuously pressing the area where the fluid is transconjunctivally. And once you see that little bit of pigment coming out, this is your end point of drainage. Now I will get hold of the two ends of the encircling band with the tie and tighten it as much as possible, so that my pressure has been built up. Now, not let the pressure fall at any point of time during this surgery. Now I put once I've done that, now fluid is gone away, retina is settled. There's some indent coming from the encircling band and from the buckle. I go ahead and do the cryo of the buckle. Very little cryo is needed. Only the exact areas needed are treated. Now I tighten my buccal sutures, get the right amount of indent. See, I have now at this stage tightened the encircling band too much. I decrease that indent so that the tightening does not exceed 15%. And now I've reached the end of the surgery. So this is a change from the usual. So I wanted to let everybody know, and we can discuss what are the advantages and disadvantages afterwards. This is just to show you some of the tips regarding now, when you do the conjunctival incision, important thing is make sure that you take both the tenons and the conjunctiva in one go. Otherwise, you end up separating the two, and you will end up with a very friable conjunctiva. So this you will see at every point, use the tenotomy to release the adhesions. I'm first going to make the relaxing incision, which and the relaxing incision, they get stuck to the muscles when you tighten the conjunctiva. So the second part, okay, this now you see with the tenotomy, I've separated out each quadrant, made sure that the sclera is clean and seen. The same for all the quadrants. And then hook the muscles. I try to avoid removing the sheath of, because the more you remove it, the more the adhesions form in case of a resurgery. So you don't want to remove the sheath as much as possible. You keep it intact and pass your bridal sutures. I think we can go ahead from here. For the encircling band, we are working at around 14 millimeters from the limbus. And you can see that important thing is to go straight in, and the burrow should be visible at
Sir,
all
there
the
is
times,
sir, there is a pop-up,
so
I
that you
think.
are at the right depth. I'm sorry.
So there is a pop-up window which has come. I think you need to cut it.
Close that.
It's on your
I'm
screen.
sorry.
There is a pop-up screen which has come.
See,
It mentions captions and subtitles.
but I can't see any. Is it okay now?
Yes, sir. Yes.
Yes, sir.
It's better.
Is it okay now?
Yes, sir. It's better now. It's fine now.
Yeah. So now we are putting now this is for the buckle, and this is at 18 millimeters in this patient. Now you see two points. You know, important that this is from happening. Yeah. So the
Yeah, the sound gets interrupted.
area you can see. So first one, then the second one.
I don't have
Dinesh, sir,
sound and it's
actually, we are
interrupted. I
unable
don't know if
to.
it's me or the connection.
No, Dinesh, sir, there is some issue with connectivity.
Sir, you can stop your video, then I think the speed, the connection might be. Your voice is breaking, sir.
I'm just trying to connect. I think I lost connection.
We need to see the end. You got us hooked up, really. It's a
I'm really
fantastic
sorry. I mean, I don't know what's
presentation.
happening.
No, not at all. I love the buckle part. It's fantastic, really. You're touching on all the nitty-gritty bits, really. It's fantastic. Thank you, Dinesh.
Akshay.
Recording in progress.
Can you hear me?
Yes, sir, you're audible. And slides are now visible.
Okay. Yeah, so I think this I've already shown. Now this is the sutures being passed. This I'm showing you the drainage of the. Now you see this is a 26 gauge needle. We've marked out the point from where I want to drain, and you can see the bevel. You only go into the extent of the bevel. You see this? You're just going up to the level of the bevel. Can you see that? And the fluid starts flowing. And the good thing about this is now I put in a swab stick there to put the pressure. I'm draining the excess amount that's coming out so that I can see that more and more is coming. Have I again? It stopped coming. Oh, okay.
It has reappeared, sir.
Yeah. So I think it was so you basically what you saw was that you can drain it without any risk of an incarceration in this. The other important thing, you've drained it and now you've gone in and seen and you say, hey, I want to drain a little more. You go there and you rub that area again and you'll find it again starts flowing very slowly. So you don't have a risk that it'll suddenly incarcerate the retina, but a little bit of very slowly it starts coming back again. So it works very effectively. Now, this was in RD without staphyloma and patients who have an anterior break, and also this is very important because I think we seem to give this a miss. I mean, I see people talk about giving a vitreoretinal surgery for every patient, which is not indicated. Now you come to patients who've got a posterior break, bullous RD or hypotony. Now these are situations where I would prefer to now do a vitreoretinal surgery. But here again, two types. One is with a posterior staphyloma. The second is who don't have a posterior staphyloma. Now, if there is no posterior staphyloma, you definitely need to, you do the vitrectomy, you think you have a PVD, still use triamcinolone and check whether there's a vitreocysis layer, remove that, and then you go ahead and finish the surgery. You don't need ILM peeling. But if you have a posterior staphyloma, then ILM peeling is extremely important. So let's come to that. Of course, we all want to do vitreoretinal surgery because it's controlled, tackles the primary pathology, risk of subretinal hemorrhage is negligible, risk of incarceration is almost zero, no distortion of the globe, no buccal infection. But the biggest problem, cataract in phakic patients, silicone oil if used needs to be removed, and if you use gas, no rehabilitation for more than a month. Now, when you have a patient with staphyloma, the specific preoperative issues are, as I said, all posterior retinal detachment, going ahead and doing a surgical intervention. Retinocysis with macular hole with a neurosense that does require treatment. And of course, if you have staphyloma and if you have RE atrophy, this will make your life this was a one-eyed patient. Then he developed a macular hole with retinocysis. But this same happened to him. Then he developed a detachment. And
Sir, your slides have disappeared. Dinesh sir, your slides have disappeared.
have I again lost you?
Yes, sir. Yes, sir. It's just been a few
Have I
seconds.
lost?
Recording in progress.
Yes, sir. Your slides are not visible.
I don't understand what the hell is happening here. Because, okay,
So there was also some audio issue
now?
for the last 15-20 seconds.
Yeah, because I had to put the other thing on. Let's see. Are we back?
Yes, sir. Yes.
Are we back?
Yes, sir. You're audible also.
Can you see the slide?
Yes, sir. We can see your slides. Audio, there's some break, but
Yeah.
yeah.
Yeah. So now, so this is now this is what I want to show you about removal of the cortical remnants. Now, if you see this, see you put in the, see when you remove these crystals of triamcinolone, you see these small crystals still left over. These are your clue that there is a chysis. And you see over here, in this patient, there is chysis, but this is not a layer of chysis. These are remnants of chysis, but they still need to be removed because otherwise, long term, you'll get a failure. Okay. Now you see this one here. Again, the same thing. You put the you put in the triamcinolone. You remove the triamcinolone, and you'll see that there are some crystals left. This is your sign. If there are no crystals, there's no PVD there. There's no layer of vitreocysis. Now you saw that. You could see that there's this level of vitreocysis coming, and this is a sheet. You see this? Now it's coming as a sheet. And it's very easy to miss it. You may think it's okay, and it'll detach later on. It'll attach initially, and you'll get a long-term detachment. And this has to be removed as far anteriorly as you can. So this is, and you see I'm going now anteriorly, trying to remove it as much as I can and cleaning it. Okay, so this is the important thing. Now, this is the third part where you see you've got this macular hole with a high myopia. And I used an MVR to blade to create an edge in the ILM. Okay, believe me, it looks as if you're doing something very scary, but it's not. It's the safest way. You just brush it and you get your edge. Is the in the ILM, and then after I had got this, after I got this break, this um, edge, I thought let me put in PFCL, and then I'll have a counter traction, and I'll be able to remove the ILM very easily. And now you see what happens. The moment you put in the PFCL, the whole area retina settles. Underlying there is chorioretinal. Yeah. So this is now the first time I did it, I lost the ILM. Now I've again created a bigger flap, and I've gone inside. I put in the PFCL back again. Now I have a large area, a large flap over here. You see this? This is a large flap. Now the important tip is do not lose your flap. You lose your flap and you will find that you won't find it again. It'll be very difficult to find it again. So make sure you try to remove it in one go. So from the temporal side, it went in one go. Now from the nasal side, I'm going. I will make sure I don't lose this. I'm going all the way to near the disc, removing this. You see the whole layer is coming together. I am not letting it, I'm not trying to letting this leave from here. I don't want to have a piecemeal thing because I'll lose it. And this went all the way around and then I took it out. If I had missed this, chances are I wouldn't have been able to find it out again. This is another patient where we had a macular hole. And this patient also had a Sionis ring, actually, and a detachment. In fact, the Sionis ring looked like an IOL. So I had a problem. I thought it's an IOL, and then I realized that, and there was this bullous detachment. We put in the PFCL to settle that, removed a little bit of the fluid, actually settled the detachment. This looks like an IOL, but when it comes out, you realize it wasn't an IOL. It was a layer of membrane there covering the whole ring. And then after we removed it, then we remove this ring now. And then I've got put PFCL over here. Now I've removed this PFCL because with PFCL I will not be. Now I'm putting in the checking out for the PVD. And then doing a ILM peeling. So only when you have enough of a flap, then you use PFCL. If you don't have enough of a flap, you will miss that flap later on. And then this was very high myope, again, a one-eyed patient. So here I've used this flap over the hole. I've put it over the hole under PFCL. And here, after doing that, then we put silicone oil. This is not under. So this flap has been put everywhere on top. Laser in this break, in this detachment, I wasn't able to find the break. So remove the. So I've done a 360 laser. Then I've done a direct silicone oil PFCL exchange. Level of careful about. Now you see over here,
Dinesh sir, there seems to have been the same connectivity issue again. Sir, you're not audible.
now am I audible?
Yes, sir. Now you're audible. Slides are visible.
Yeah. So when you this is the patient where there's now, see, you're removing this. Now you remove this vitreoretinal layer. Now you have a tendency to move as if you understand the config is a high myope and you have a posterior staphyloma and you have a sudden edge and you see what happened. I hit the edge. And so be very careful when you go into the periphery.
So we cannot hear you, Dr. Dinesh. It's muffled.
I'm sorry.
The sound got muffled in the last part. Maybe if you don't mind starting from
Where?
when you were talking about like peeling the hyaloid and why is that? I think
Okay,
maybe
should I'll
yeah.
just go back. 1 second. I go
Yeah,
back.
yeah.
Okay.
No, I think this step is
This is
good. The
okay?
next slide from the start of the video.
This one is okay?
This one is okay. The next
Yeah.
one.
Oh, done before this.
Yes, this one is fantastic. The video. Start from here.
Yeah. So did you see this is the one which had the Sioni's ring. Did you see
Yeah,
this?
yeah, we saw that. No, the next slide is fine. And when you were talking why
Yeah, so
it's
that is
important
the
to
one I
take
think which
off.
is important. Yeah, this is the one which is important. This is the one where you see now you're removing this hyaloid.
Yeah,
And if you're not careful to keep looking at the point where you are going in the periphery, suddenly you will hit the edge of the staphyloma.
yeah,
So this is very important that you don't, we have like here, I let it go to the edge and I was not seeing the edge and I got a break. And the break
yeah.
is right at the edge of a staphyloma, which is very difficult to manage. So it's very important, move slowly and keep looking at that area for where the slope of the staphyloma is changing suddenly. If you're not careful about that, you may hit the staphyloma. So
Especially if you're
keep
using a high
gradually.
magnification lens, right? So the view is
Yes,
like
which I
small.
often use because
Yeah,
yes,
the view is
the view is small. Yes, so I
Yeah.
prefer to use that because I have a very clear view of what I'm doing. But the disadvantage is that I have to make sure I move along with it. Okay, so now we have the situation where you have an RD with or without retinoschisis, no macular break. You don't need an SRF drainage in this. If there's only an RD and there's no macular hole, you don't need, you will do an ILM peeling if the staphyloma is present, but you don't need to do SRF drainage. But if the RD extends beyond the posterior staphyloma and there's a macular hole, now this is a problem because you've got a posterior staphyloma, you've got a terrible RPE. So in this case, I would use the PFCL to flatten the posterior pole, put an ILM flap onto the macular hole, do my retinotomy just beyond the edge of the staphyloma where I know it'll be easy to do the laser. Also, since the PFCL is flattened out everything up to the staphyloma, this fluid will be easily, completely removed. So, and then I'll do a silicone oil endotamponade for this patient. If there's an RD within the posterior staphyloma and there's a macular hole, I'll use the PFCL to flatten the posterior pole, put in the ILM flap on the, do the ILM flap peeling with the flap on the macular hole, do the air fluid exchange, and then remove the PFCL very slowly from the nasal side near the disc and put in silicone oil endotamponade. The important thing you notice are two critical parts when there is a posterior staphyloma. One is the ILM peeling. The second is the vitreoretinal removal. Vitreoretinal removal is important whenever you do a vitreoretinal surgery for any high myopia with detachment. So these steps, if you take into consideration, it helps you to allow the retina to fall back into the staphyloma and the retina settles down. I have, frankly speaking, never felt the need for a macular buckle. You know, people talk about doing macular buckles, but I have not felt the need for the macular buckle because the retina is more or less always fallen back. So therefore, this issue did not come up. And that's the reason why macular buckle is not something that I do, at all. Uh, Myopic RD management is challenging, but very rewarding. It is some important that you select your patient properly. You do each step very slowly, meticulously, and chances are you will be successful in your surgeries.
Sorry, Dr. Dinesh, can I have a special request? Slide
Yeah.
23. I just got excited about how you shortened the buckle, but I didn't really get it. And
Okay,
I think it would
I just
benefit
go
the
back.
audience a lot because this is one
Okay.
of the things really that intrigues me, how to get like a 12 millimeter shortening of the buckle.
Okay,
I think it's slide 23
I'll go back.
because at the end the voice was great.
No,
So
I know
maybe we
what you're
can.
looking for. You're talking about.
Yeah. I'm not sure. How did you come up with the? Because the problem is, yeah.
Yeah. Okay, so now see, we know that at the equator, the circumference, the radius is normal eye, 12 millimeters radius, 24 millimeters diameter. Now, the circumference of the eye is 2 pi r, 2 into 3.14 multiplied by the radius. That's around 72 millimeters. Okay. So if I want to cause a 10 millimeter shortening of the circumference, then it's around 7.2. But rather than making it 7.2, I just make a round figure of 8 millimeter for myself. So 10 millimeter, 8 millimeter, 10 percentage, 8 millimeter. 15%, 12 millimeter shortening. Now I have to say, how will I know I've done 12 millimeter shortening? So initially, when I put the encircling band, I just put the encircling band, just caressing the whole eyeball in all the quadrants. Okay. The
Yes.
sutures have been put, the encircling band sutures have been put. They're just caressing the eyeball, they are not tight. Now, at that point of time, I've removed, if it's a encircling band is obviously very large. So I've removed the excess so that now on this side, I have some 5 millimeters. On this side, I have some 5 millimeters on either side of the encircling band knot, right? Now, when I tightened it, when I decided to tighten it, I tightened it Now what happens? This moves forward to this side. It may be more, it may move forward to this side. So now this amount is the excess tightening I have done on this side.
Right.
See my arrow? Can you see the arrow?
Yeah, I think my question is how do you make a mark? Do you make a mark with a pen?
No, I measure it with the
Okay, but
caliper.
how do you know like this is like the red arrow? How do you know that this is the place of the red arrow after you pull?
Yeah, no. So this is this from here to here I've measured.
Ah, okay, right. I got you. Okay, I understand now.
And
Yeah.
from here to here I've measured,
And then you know the difference. Okay.
right?
Yeah.
Now I have increased it. Now what I do is I cut it so that it's back to the level of the red arrow. So
Right,
if
right,
it
right,
was 5 before, it's 5 later. And I
right.
make sure that I pick this up and put it on the side. I pick this up and put it on the side, put them together. Now I measure these two, right?
Very nice. Very nice. Thank you so
Right?
much.
So if
Yes.
it's
Nice.
so you know exactly how much tightening you've done, and you will never have that fear that you've caused over tightening. You never have that fear that you can get anterior segment ischemia. So for me, anterior segment ischemia doesn't enter into a differential diagnosis because I've never let that happen.
Very nice.
Okay.
Thank you.
So I'll stop sharing now. Yeah. Anything else, or should I stop sharing?
It was a great presentation, Dr. Dinesh sir, with the nitty-gritties of buckling surgery as well as VR surgery in myopic retinal detachments. I'll like to welcome Dr. Jayant Kumar, my co-moderator for the evening, who's in charge of ASGI Hospital at Ranchi and has been with our hospital for the last 5 to 6 years, has worked at Jamshedpur Center as well, and is a very learned ophthalmologist, a very renowned VR surgeon, to take forward the discussion with all our panelists. Dr. Jayant.
Yeah. So thank you very much, Dinesh sir, for this wonderful and elaborate and passionately made slides as well as nicely collected videos, which have shown us all forms of surgical management of patients with high myopia and retinal detachment. First of all, I would like to start with a few more questions on the techniques which you have shown, sir, and a few queries. Regarding the modifications which you have done in your scleral buckling technique. So, since you do cryopexy after tightening the buckle like encerclage, sir, so while doing cryo, you do it from over the buckle elements?
So what I do is I place the cryo probe. I'll lift up the buckle slightly and I
Okay.
put it under that. Now there are two good things about this.
It
Once
will
I've
not
placed
slip.
it there, it cannot move,
Yes,
right?
yes, yes.
The
Okay.
I have actually once had a situation when I was a consultant. I have had a senior resident inadvertently cryoing the optic nerve. Okay.
Okay, okay.
So just keep in mind because he kept on feeling the shaft, not realizing that that was the shaft and not the edge, and the end went into the.
Optic nerve.
This you are 100% sure you won't make that mistake because
Yes,
the buckle will hold you in position, will not let you go that bad, that
yes,
posteriorly.
yes.
But once you put it there and it allows enough movement. So what I do is I ask the assistant to hold the bridle suture. So they hold the bridle sutures in a wide position, widely like this. And that allows me the move the luxury of movement of the probe under the buckle, right?
Yes,
And
yes.
also make sure I don't go posterior. It stays in that plane also.
And sometimes there is severe hypotony following SRF drainage. In that case, even if I guess if we cut 12 millimeters exactly, there may still be some
No,
hypotony
no,
over
no, no,
there.
no. Now, you don't cut the 12, two things.
Yes, sir.
First of all, if it is a very bullous detachment,
Yes,
in
exactly.
today's world, no buckling. I don't do
Okay,
buckling.
okay,
Okay.
okay.
I'm very clear. If it's a very bullous detachment, I don't want to get into a buckling procedure. Okay.
Yes.
But I can tell you the times when I used to do it. You can do it. Now, basically, what happens is you put in the, you put, now small tricks, you may say unnecessary, but like I know it's a bullish, relatively bullish detachment. I need my buckle to be, I need one suture in the inferotemporal quadrant, one in the superotemporal quadrant. But I'll put two. You know why?
Okay.
It will tighten, no?
Okay. Okay. Yes.
It will
Yes.
give me the tightening. And initially, now, so when I did the drainage, the fluid is more fluid has gone, the eye is becoming softer.
Yes.
Now I'm not tightening 12 millimeters, I am tightening full.
Okay. Okay.
I will
Okay.
go to 12 millimeters later.
At the end. Okay. 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 Okay.
Till the thing is full. Now I've got a very, very tight insert band, but I have got indent coming from my buckle, and I've got extra sutures. I will now adjust my buckle sutures, loosening the encircling band to the level I want. Okay. I'm slowly decreasing. Initially, I tighten the encircling band a lot, right? To get the
Yes.
right pressure. I don't want low pressure. But now, once I've done that, I've seen inside everything is okay, but I've got an hourglass kind of picture coming, right? So
Yes.
I will first tighten one, I will tighten one buckle suture, loosen the
Okay.
encircling band a
Okay.
little bit.
Okay. Okay. Yes.
Now
Yes.
tighten one more, loosen it a
Okay.
little more,
Okay. Okay. Okay.
right? And then you know what will happen over a period of 10 to 15 minutes, you'll find that you'll get to the normal pressure, normal tightening, and you would have done fairly large amount of drainage also. So you can
Okay.
do that also. But in principle, I don't do drainage when it's a very bullish detachment. I'm just telling, I'm giving you the tip how you can do it if you still want to do it.
Yes. Yes.
Uh, Dr. Talwar sir, Mudit here. Can I ask a question, Dr. Jayant?
Yes. Yes, sir. Please. Please go ahead.
Sir, thank you so much. Great talk and very informative as always. It's always such a learning to listen to you. I just had sir one question. In eyes where you do an ILM peeling, how important is the size and extent of the ILM that you peel, and to what extent do you always peel? Is it always a very large peel till the edge of the staphyloma, or how do you measure? How do you titrate
Yeah.
the peeling? And
Yeah.
just
So
one more second question in this is, do you always use oil, or is there a role of gas also in some of these cases?
okay, so basically, in a patient with high myopia with a posterior staphyloma, I will try to peel as much as possible up to the staphyloma edge. Okay.
Yeah.
That goes without saying. If I'm not able to do, it's a different thing. But I will try to do as much as I can. Okay.
Yeah.
Now this comes the second question: is there a role of gas also? The role of gas is in those patients. You know, you'll have some patients who got high myopia, posterior staphyloma. They're developing some retinoschisis. No macular hole,
Sir, we
and
lost.
then the vision is dropping. I told you one that situation. Say vision has gone down to 618, 620. Here I will do the ILM peeling, but I will not. Here I will not put oil. Here I may leave on gas.
All right. Thank.
Yeah. Dr. Mudit, do you have any more question you can ask?
No, nothing. I'm good. Thank you so much, sir. Yeah.
Okay. And one more thing I would like to ask to Dinesh sir, that so you have spoken about scleral buckling and vitrectomy. Uh, are there cases where you prefer buccal vitrectomy still? Like buccal with a
So
sensor class and a
vitrectomy.
vitrectomy.
So supposing you have a high myopia, supposing you have a young patient, especially if it's say something like with high myopia, but also say FEVR or something, then I want it.
Okay.
There it's not easy to, you can't remove the anterior vitreous. You will need the help of the buccal. And for me, buccal does not mean a band in this situation. It means a
Okay.
buccal.
Okay. So next I would
It's
like
not
to ask
360.
Mahesh sir to please give
Sorry,
his
The only thing is not 360-degree buckle. It's the
Yeah, okay.
inferior part of the
Okay.
superior. I may not put the buckle. Superiorly encircling band is enough.
Mahesh sir, we would like to have your quick comments, and also something I would like to ask you is, how do we preserve the art of scleral buckling? You have recently mentioned in an article in IGO in May this year that uh, scleral buckling will always have its relevance despite it being a 60-year-old technique. And you have mentioned some points in the article. So I would request you to please throw some lights on how can young doctors continue to practice scleral buckling, and also your pearls of wisdom on sutureless buckling and implant versus explants.
Thank you, Dr. Jayant, and thank you, Dr. Dinesh, for a wonderful lecture as well. Yes, there is always a role for scleral buckling, because there is no point in going inside in an eye where you don't want to do a vitrectomy. Particularly in myopes, what happens is if you do a vitrectomy, then the patient will develop a cataract, and then you do a cataract surgery, the patient develops an anisometropia. So because necessarily you have to take care of the other eye. So when you can manage with a buckle, you can pretty much not go inside the eye and make sure that the retina is attached without too much of a uh, refractive errors. Like if at all, it's going to be about like 1 or 2 diopters of myopia, which is going to be the increase in that. So I learned particularly younger patients where the vitreous is densely attached, and if it's a peripheral break, there's no point in going ahead with the vitreous surgery. You can very well manage vitreous, because vitrectomy is going to be very difficult in these patients. You cannot peel the vitreous sufficiently enough, and will need a tamponade as well. So that is the reason, like, scleral buckling will have a role, and it's just a question of how do you go about doing the scleral buckling. That's all. It's pretty the art of learning scleral buckling is becoming a little difficult, because like people stop using the indirect ophthalmoscope. That's the issue. So there was an article which we have published in 2018 about the newer techniques. So where you can do some small modifications which will help you do the buckling learning, the process of learning buckling very easy. So Dr. Dinesh was mentioning about like one of his residents cryoing the optic nerve. What we can do is we can actually have an illuminated optic nerve and illuminated cryoprobe and an illuminated localized indenter. So what you can do is to take a 20 gauge light pipe which is discarded, bend the tip a little bit, and use that to localize. So the illuminated tip will tell you exactly where the localization is. Similarly, take a naked fiber of the fiber optic which you have discarded, and use a small bit of the IV tubing threaded onto the sleeve of the cryoprobe, and insert this naked fiber into that. So that way you have a illuminated cryoprobe tip. So when you depress, you will be when you are able to on the indirect ophthalmoscope, you know exactly where the cryoprobe tip is. So this way, you don't inadvertently cryo posteriorly. So that way you can. So that article gives many small techniques like this, which you can decrease the learning curve as far as the buckling is concerned. Sutureless scleral buckling is what I do most often right now. It's pretty easy to do, except for the fact that the area of the buckle should be about half a quadrant. That's about 1.5 clock hours. If you want to buckle, then that would be ideal to do a sutureless buckle. So what we do is to place 2 tunnels on either side after localizing the break, and slip the buckle underneath the band. The width, that is if you buckle half a quadrant, what happens is when the encircling band passes through it, the encircling band effect is just adequate enough to press the buckle to give a good buckle effect. So you don't need sutures for this. And you can do multiple sutureless buckles as well. So it can be one in one quadrant, one in another quadrant, and you can in the same quadrant as well, you can make three tunnels, so that, and place 2 pieces of sutureless buckle between the 3 tunnels. So that can also be done. Most often I do sutureless buckle. The advantage of sutureless buckle is, of course, like you avoid the sutures, which the process of taking sutures can have a risk of penetration, number one. And sutures are the ones which are responsible for buckle infection. That's number 2. And the sutureless buckle, as such, the procedure is easy to learn, and like it works quite well if the case selection and the location of the break is appropriate. So is there anything else you wanted to know?
That's these are very nice tips, sir. One more thing is like sometimes the instruments do not reach the posterior pole well. Like what modifications do you use in those conditions, sir?
Yes, there are forceps and which are available, which are long as well. But for practical purposes, what I would do is to, if I know that the globe is particularly long, then place the sclerotomies posteriorly, 4 millimeters, and you can do a transillumination, identify the secondary body, and you can place the sclerotomy even at 5 millimeters as well. And the trocar cannula, the cannula, if you remove, that gives you another additional 2 to 3 millimeters of reach. So the above the instrument doesn't hit the cannula. So that those are things which can be done. And there are described techniques of like you can sometimes when like inadvertently when the patient loses the block during the surgery, you can give a block on the table, little bit of a block, so that will push the posterior pole a little bit above. That can also be used. But more often, what I would use is to remove the cannula and make a posterior sclerotomy, and then these are the techniques I would use. And a couple of techniques, if I can mention, as far as like the localization is concerned, Dr. Dinesh was mentioning trans through the lid. If you're able to localize the break, then you know that this patient can be buckled. I would add saying that like the patient's eye is in a primary position. Don't ask the patient to look up or down. The patient's eye is in a primary position. If you're able to depress the break in the clinic, then you know that like you can buckle these patients, and you can go posterior as well. And it's not necessary that like it has to be indentable on pre-operatively as well. Number one. Number two is like in bullous detachments also, I would do buckle even now. What I would do is like to avoid the hypotony, you can do an infusion assisted drainage. So in the same quadrant where you're planning to drain, say if it's an inferior temple quadrant, you can put an infusion, a 25 gauge infusion, and turn on the infusion, and then roll the eye that way and then drain. So that way, like you're turning on the infusion, like as the fluid comes out, the fluid going inside avoids the hypotonic from coming inside. So this is a technique which is again I have described in that article. Instead of repeatedly draining, injecting, repeatedly draining and injecting, that hypotony and increased pressure is the one which can risk the occurrence of choroidal detachment. We can do this. Put an infusion. Only thing is the infusion bottle should not be very high, because once the fluid comes out, and usually this works very well with the needle drainage technique. If the cut down technique, then there is a possibility of retinal incarceration. But with the needle drainage technique, the risk of incarceration is very less with the infusion assisted drainage. And the little modification of what Dr. Dinesh Talwar showed about the needle drainage technique is I go tangentially and then withdraw the needle. I keep the needle in the track. So the bevel of the needle is in the track, so that like the track is kept open for the fluid to completely drain. I don't go inside, come out, and leave it for it to drain. I keep the needle in the track so that like the fluid drains completely. Then you can do that. Another thing in patients with posterior breaks where you are not able to identify the break, despite all our, particularly in staphylomas where we are not able to identify a posterior break, you can use a sub retinal BBG, a diluted BBG. So the earlier technique described is transretinally, you can inject through a 38 gauge needle into the subretinal space and put a bubble of perfluorocarbon and roll the eye, and the subretinal BBG will come out through the break and identify the break. So, but my modification is transclearly inject the BBG. So dilute the BBG, go transclearly inject the BBG, put a bubble of perfluorocarbon posteriorly and roll the eye, and the subretinal BBG will come out through the break and identify the break as well.
Okay. Those were really nice tips, sir, and we will definitely go through your article of 2018 as well. I have a question for Dhanashree, ma'am. Ma'am, am I audible to you?
Yeah, yes.
Yeah.
Correct.
Ma'am,
Yeah.
so like Dinesh sir showed elegant looking technique of using an MVR to raise a flap for ILM peeling. Like, what are your preferred techniques to get the first peel? Like, do you also first try to go ahead in a like detached retina and then use PFCL, or you have your own modifications, or do you go for pinch and peel? Because the contrast is very poor and often stain is not taken up well.
Yes, of course. But if the retina is attached, In that case, then you can, stain the retina once again if the staining is poor. But I most often use the pinch and peel technique,
Okay.
and that often works with me. But sometimes, as you said, sometimes the retina may be detached or the contrast is very, very poor. It's very difficult to see. In that case, then it helps to put the PFCL. So you can stain the ILM and then put the PFCL, because PFCL gives more definition. You are able to see the macular hole better, and then you can peel under PFCL. And sometimes if the retina is very tautly pulled, in that case then you can use some other forceps, or even what Dr. Dinesh has described. Maybe you can use that MBR knife to peel the ILM, or you can even use the finesse loop.
Okay.
I'd like to just clarify about what I said. See, you in a detached retina,
Yes, sir.
the MVR works very well.
Hmm.
In an attached retina, what I find safest is actually a fresh diamond dusted sculpture,
Okay.
because that just a little gentle this thing and near the vessel. See, what happens is where the vessels are, at that point the ILM breaks off more easily.
Okay.
So if at that point you gently use a fresh diamond dusted scratcher and just brush it, you'll find you'll get an edge.
Okay.
You won't get it with an old one, I can tell you this also. So I end up spending 5,000 rupees every time I'm having any trouble. So but in a detached retina, this diamond duster will not work. There you have to use either the MVR to create an edge, and then you can use, instead of using the pinch and peel from the beginning, I'll use the diamond duster to create a small edge. And then now you don't need to pinch. Now you just actually have a flap which you can extend with the forceps.
Okay.
That's the
The small tip is like these are the eyes where I would do the staining under air. So in myopic eyes, like I would usually do an FG, then put a stain and then wait for about 30 seconds to 1 minute. That stains the eyelid beautifully. In contrast to any other situation, you don't need to do it under air.
Yes.
Yeah,
One
and
more question.
very often I find that in high myopic eyes, actually, I prefer to do this retinal autograft, because I feel that because already there is a lot of atrophy around the macular hole, and sometimes the visual prognosis is poor. So if it is, and also even with this ILM, inverted ILM and all, the chances of macular hole closure are a little bit poor. So instead of that, if you do a retinal autograft, the chances of closure of the macular hole are slightly higher, and the visual recovery is also slightly higher.
Mahesh, I'd like to ask you, what about, instead of using under air, would you consider using ICG? Because that stains better than anything else. But the only thing is, I'm more scared of it.
Yeah, well, but then like one thing is I have never used an ICG. So the myopic eyes doesn't seem to take up stain easily. That's the reason. Do an FG, put the dye, then replace the air with the fluid. By the time the dye gets washed off and this ILM stains well. I have never used ICG, Dr. Talwar.
Neither am I, but I
Definitely.
was asking your opinion that maybe it works. I'm scared of ICG, actually. Frankly speaking, I'm more scared of ICG than any other dye.
Can I add
So
something
I
quickly?
always use the dye under air. But one more advantage is if the retina is detached, then if you do the staining under air, then that prevents seepage of the dye under the retina. So subretinal dye is even more toxic. So you would not want the dye to go under the retina. So it is better to do the fluid gas exchange, fluid air exchange, and then put the dye, so that the dye which enters subretinal space is minimal.
But one caveat when you are working under fluid, under air, you have to titrate it much more. I mean, because like as Mahesh said, then you don't put it for more than 30 seconds to a minute. Whereas when you do it under fluid, you use it for around 2 minutes. It stains better, but the toxicity also will increase a little more.
Okay.
So we put it hardly for a minute, not more than a minute.
My next question is to Dr. Ahmed Salam. Are you there, sir?
Yes, I'm
Yeah.
here.
So, I would like to ask you that how much does refractive procedure mean to you when you are deciding the line of management for a patient who is high myopic and has developed retinal detachment, like patients who have undergone refractive procedures like LASIK or phakic often they don't want any myopic shift. But as a vitreoretinal surgeon, do you think we should think in that line, or we should just be concerned about attaching the retina?
Yeah, I think it's a great point, and it underscores really an important point. I mean, you're the advocate, you're not the boss. The patient is the boss, right? So I tell the patient that there's no point really to worry about refractive surgery, what you've done and the refractive surgery of the eye if you're going to lose the eye. So let's focus on the retina now. Then later on, you can be your if your retina is attached, we can try to address your vision with different ways, but there's no point now waiting about. But sometimes patients like dictate what you want. For example, they say, I don't want a buckle. This rarely happens, and usually patients listen. But I think the important thing is to educate the patient, to tell them what you would suggest, and then you have to listen to them. It's their eye.
Yes. So one case scenario was very unique. A patient had an inferior retinal detachment with fluid almost reaching very close to say 2 disc diameters away from the arcades, inferior arcade. The
Yeah,
patient was advised scleral buckling at one institute and a barrage laser which would anchor till aura in another institute. They
yeah,
just called me for an opinion. I told them he was not told about myopic shift. So I told them that if you
yeah,
go for buckling, there can be a myopic shift. But if you go for barrage and if it works, you won't have any shift. And he underwent barrage and he's doing well for the last 6 months. But he's extremely happy that almost like I saved his LASIK procedure and he doesn't have to wear glass again. So should we increase our threshold to try for like barrage laser as an option to anchor retina even
yeah.
if the fluid is coming closer to arcades, or should we just go
Yeah,
ahead
I
with
think that's a
buckles?
good point, really. In my experience, I think barrage, if the fluid really is more than subclinical, which you can define as like 1.5 hour outside the break or reaching to the equator, I feel it just after a time it fails. So I would usually encourage either vitrectomy or buckle, and it depends. If they have no PVD, young patient, tears that I could see nicely, then I put a buckle. I tell them I like segmental buckle. I don't like encirclement. I like segmental buckle. I like to do the minimum required. I just don't believe in like prophylactic treatment with laser, prophylactic buckle of none of areas where no breaks. I think I just examine the patient. The breaks I see, I just buckle. And the one thing I like the segmental buckle is initially you have a significant astigmatism, but as the suture slackens down, usually that corrects after a year, which is different from the band. The band you have like permanent refractive shift, but that's not the main issue. The main issue is just less is more, in my opinion. But the refractive shift with the segmental bucket tends to correct over a year because the sutures effect like goes away.
Okay. And
Can I just add one thing very quickly with about the ICG dye? I have good experience with ICG. When I moved from UK to the US, I used ICG for like 6 years before blue dyes were available there for staining as in the UK. It stains nicely. You still get the same problem with myopia. There's no really like the background reflex is not the same. It stains nicely, but it is toxic.
okay.
Yeah.
Dr. Soumil, sir, are you there?
Yeah, I'm very much here.
Yeah, sir. So, we would like to know about your experience with base dissection. Often, base dissection in high myopes is something which can be a little tricky. So, you have been doing base dissection under air. Can you throw some more light on it?
Yeah, I would definitely like to. Great talk, Dr. Dinesh sir, and very nice inputs by Dr. Dhanashree, Dr. Mahesh, as well as Dr. Ahmed. So before I go on to this, while we are talking about segmental buckle and not inducing a refractive shift and things like that, I have a very short video, if you can allow me to present, is my way of doing scleral buckling without even opening up the conjunctiva 360, opening up in just a small segment and doing a segmental buckle as well as band without sutures. If you allow me, it'll just be a minute or so. Is
Yes,
that
sir.
okay?
Please go ahead. Please go ahead.
I
And Mahesh sir had some inputs.
No, about the barrage laser. So the problem is like if there's significant amount of retinal detachment and if you've done barrage laser, what happens is this sets up an inflammation subsequently, and you will see neovascularization developing on these in this retina, and particularly in myopic eyes. So they tend to have a vitreous hemorrhage and anti-halide proliferation. So I am not a very big fan of doing barrage laser for detachment which are more than subclinical. I would say subclinical is around 4 to 6 disc diameters. Larger than that, I would not be comfortable doing a barrage laser, rather to do a buckle, because these patients
Because
do develop problems later on.
it matters.
Yeah, Dr. Jain, can you see my screen?
Yes, yes. You can
So
play
this
it.
is basically a buckle that is done in a segmental manner. I have made a fornicial incision. I have not even taken a limbal incision. This leaves my conjunctiva absolutely virgin all around, probably to do a trab or anything later on. I have just here tagged one muscle, just one single muscle. It's just a minute's video. After that, I take one scleral tunnel on one side of the muscle that I have tagged, and a similar scleral tunnel I make on the opposite side. So this is, if this is a 6 o'clock position, this would be probably 4 o'clock and the other side would be 8 o'clock. And once I've done that, what I do is like how one would pass a band. I would start from one tunnel, push it under the muscle, take it outside of the other tunnel, now roll it back upon itself. I call it a shoelacing. And what I do is, after I do that, under the muscle, I put in a Watzke sleeve here and I tighten the band under the muscle across both the scleral tunnels. In this way, I can achieve the height of the indent how much ever I want inside without having any encerclage effect. So this will avoid any refractive shift. It will have a segmental effect. I don't even need to really suture the conjunctiva here. Here I've done a combined procedure with vitrectomy because there was inferior PVR. I was not very convinced of putting a 360 buckle. So I've done a vitrectomy, but this is mainly to just highlight of the kind of height that I would achieve by doing this procedure. You see this height, you're seeing the inferior break sitting here very well on the, there are two inferior breaks here and there was a star fold here. You can very well see it flatten over the band, and then you can probably laser out as well as the flatten the star fold after removing it. So this is just, I'll just stop my video now and stop screen sharing. So I don't know whether you all got the concept, but it's mainly towards trying to preserve not only the conjunctiva, prevent refractive shift, as well as achieve a sutureless way without any much complication of doing a segmental buckle. I call it the shoelace technique. I don't know whether anyone is doing it as of. So
That's
Yeah, I
really
think it
nice.
was published by Saudi group as well, something similar, really. I think in Brief Retina.
okay, the same segmental technique, or it was a
Uh,
360
no, I think
encirclage.
it was a band. It was like a band
Yes.
with
It was a
left and side
360 encirclage with a fornicial incision. They made, in
Correct.
fact, 4 fornicial incisions and they passed it
Correct.
each muscle in a localized
Yeah.
manner. But
Correct.
this is doing it in a very segmental manner towards achieving exactly the aim what Mahesh sir and Dr. Ahmed you all proposed with respect to segmental buckling without achieving a myopic error shift or refractive error shift or anything of that sort.
I think you can publish it as a surgical technique.
So is the buckle?
You can also put a buckle underneath the band, like how Dr. Mahesh
Just
sir
folding.
mentioned it, between which will straddle between the two tunnels. You can, if you want more height. But usually just by tightening it, you will get sufficient height as long as the break is anterior to the position of the band that you have put. In fact, I would err more on the part of putting the band more posterior because I'm just straddling it between two tunnels. I can go posterior such that the break goes anterior rather than using a larger buckle.
I have a
Mahesh
very
sir, your
quick,
comments?
yeah.
What you're saying is like you're passing it between two tunnels, then backing it back, and
Yes.
then using a sleeve.
Watzke sleeve, yes. So more,
And when you go ahead, go ahead.
no, sir. Go ahead. So finish.
No, no, when you pull on it, like won't the edges of the distal edges of the tunnel tear?
Theoretically, yes, possible. But if the tunnel is stout enough, I'm not achieving that much of a height really to be able to, squeeze it so much that it creates that much of an indent. I just want a very light circumferential indent. Now, this indent is very much contrary to the kind that we achieve in a technical buckle. In a buckle, we try to have an antero-posterior indent and not a circumferential one. But in this, we achieve a circumferential indent. So the tunnel has not frayed. It has not given way so far. But yes, it is a theoretical possibility.
Yeah, as usual, you do think differently, Dr. Soumil. Congratulations on your thought process. Let me see if I can try it out and see if that's my only concern. When you double it back and then pull it, the distance of the tunnel, whether it will give way, and it may shorten the sclera to some extent, like circumference, it may shorten the sclera in that particular segment. That can also give rise to a buckle effect. Yeah.
Astigmatism, yes, maybe, but not definitely myopic shift.
So what is the longest follow-up you have had for
Wouldn't
such?
it be easier?
Yeah, go ahead. Dinesh, sir. Someone was saying something.
Soumil,
Can I say something, Dr. Soumil?
Yeah, please, madam.
It's a very, very interesting concept that you have shown. My doubt is you can in fact even call it as an adjustable buckle, because you can always later on adjust the height. If after 2-3 days, if you find that the height is not good, you can readjust it. But my doubt is that you are folding that buckle onto itself. So over a period of time, do those edges where the buckle is folded, will that tear? Because it is
That's the
sitting in
same
the
doubt
folded
Mahesh sir also
thing.
raised. Probably,
No,
I mean,
he
I
was
have not
talking
found it.
about the flaps, the scleral tunnels. I'm talking about the buckle itself.
Not really. I didn't understand that exactly.
The buckle you are pulling
the
from one side
buckle will
and
actually
then
create
pulling
height.
it, like the shoelace. So where the buckle has turned, do you think it will, get frayed or get broken after some time?
Not really. They're quite malleable that way. I don't feel that would be the case. In fact, the scleral tunnel coming off, yes, that is a theoretical possibility for sure, but not the buckle breaking away. In fact, Mahesh sir, to solve that issue, probably you can put a buckle as a necessity in between the two tunnels so that it goes up to the edge of the tunnel. That will also probably prevent the edge of the tunnel from turning around that much.
No, I'm talking about the distal ends of the tunnel, because where the encircling band is turning over,
So you can put a
that's where the
buckle
traction is.
at both the ends. So probably that will prevent the band from the tunnel from turning that much inward when you try to shoelace it.
But the buckle comes between the two tunnels, right? Buckle doesn't go
Soumil,
beyond the two tunnels.
Yes.
So
Between the
then
two
where do you
tunnels,
put a
but it can
buckle? So
straddle on the tunnel.
Soumil,
Yes, sir.
I think instead, why not
So we
in
can't
same
hear you.
tunnel?
I think your internet connection is slightly weak.
Can you hear me now?
Yes, sir.
Can you hear me now?
Yes. But it's breaking in between still.
If you put a double buckle, that means you buckle in the same area. You
Dinesh sir, actually you're not audible. Maybe you can post your question in the chat.
I think what he's trying to imply is you're anyway achieving twice the size of the belt because you're folding it upon itself. So probably wouldn't that give rise to extrusion issues is probably what he's trying to imply. I think that is what I get from his question.
Dr. Anusha has a query whether it is going to
about
press against the muscle, but I think Dr. Soumil, your technique is that you're not going to cross the muscle at all. You're just
No,
going to go around.
it is going to cross. It is going to go under the muscle.
Okay.
it is going to
That is the only way it will stay, right? So it
Okay,
is going to go under the muscle. So there is a possibility. But even if it goes twice under the muscle, it's
but
still a band. It's not a buckle. So if the buckle is able to not cause damage to the muscle, I doubt whether twice the band will.
Okay. Dr. Mudit, are you available, sir, for taking up a question? I think,
Sorry,
sir,
Dr.
I
Jayant, I
think
left the air thing out.
Yeah,
So
I think he had messaged he's unavailable. So one more question for Dhanashree ma'am. Ma'am, you have a publication on pneumatic retinopexy and which also describes doing it in recurrent detachments, like when there is a limited recurrence. So in cases of high myopia, in case of a recurrence, what are the conditions in which you would consider pneumatic retinopexy as a rescue procedure?
Not just high myopia, but otherwise also, if you have a recurrent RD, which is localized RD, just maybe one single break is there, where you think also it is superior clock hours, not inferior. That would be and no PVR at all. So that would be an ideal situation. So it's a small area which needs to be tackled, and already the patient has had buccal or vitrectomy, whatever the case. So in this situation, it would be good to do a pneumoretinopexy. In high myopia, but actually you have to be a little bit more careful because high myopia is a little bit risky. The pneumoretinopexy might not be that successful in a high myopia patient. So you have to assess the patient very well. So if you think that there is no vitreous traction at all, there is no PVR, in that case, and there is just one single break. Often, because of lack of contrast, you might miss other breaks. So you have to be very certain that there are no other breaks. And in that situation, then you can go ahead and do a pneumoretinopexy.
Okay. And you have one more publication in 2022 about prophylactic treatment of peripheral degenerations, especially. So, what do you suggest in today's date, ma'am, for patients with the retinal detachment in one eye and other eye having simple lattice degeneration? And suppose the first eye had a detachment with no detectable breaks and just one lattice degeneration. So, would you suggest doing prophylactic treatment of simple lattice degeneration in the other eye?
Yes, it is considered a high risk situation if you have a RD in a one eye and the other eye has only lattices or even atrophic folds. It is considered as a high risk situation and it is advisable to do prophylactic laser to the other eye. So
Okay.
definitely I would advise whether the patient is symptomatic, not symptomatic, no matter what, the laser has to be done. And
Okay.
I think Dr. Anusha Reddy has asked in the
But
chat box,
one
how would you
thing,
titrate the gas?
Yes, ma'am. That's a
And
question.
yeah. So if it is a very large eyeball, then you may have to inject a larger volume of the gas. But otherwise, normally what you inject about 0.3 cc is what we inject because when you inject 0.3 cc, the arc of contact is exactly 90 degrees. So that is enough for you to, the tamponade a quadrant of a break, one quadrant.
Okay. I think Mudit sir, you are back with us.
one thing I'd like to talk about, Jayant, we were talking about lattice. In high myopes, sometimes you have lattices and you have adjacent areas of retinoschisis. Those are the ones you have to be very careful because accelerate a detachment by doing a laser in those areas. You have to routine lattices, yes. In a fellow eye, you want to treat, but lattices with peripheral areas, what look like retinoschisis, be very careful. Either you're covering the entire area, you're not leaving anything uncovered, or if that is not possible, it may be better to leave it alone till he gets a detachment rather than
Okay.
fiddling around with it when the retinoschisis is there.
Yes, sir, Dinesh, sir, I agree. Sometimes the patient will have multiple rows of lattices. So in that situation, then your laser is going to be very excessive, which will cause vitreous contraction and vitreous traction. In that situation, then probably you may wait and watch. But if it is just one simple lattice or one simple hole without any vitreous traction, you can laser.
Can I add something on the laser treatment
Not
for lattice? I never treat
pointing out
them.
a
I don't treat.
specific
There's really, like, if you look at the evidence, it's hard to conclude really that treatment is necessary. I mean, even the recent evidence that if you have a stickler in the other eye, and there are a couple of retrospective paper I think the significant bias in these two articles. And UK standard is you don't treat the other eye unless they have an asymptomatic pathology. I feel less is more, and as mentioned here by Dr. Ratra and Dr. Dinesh before, there are cases where you can cause problems. The problem also when you treat lattice is when they get breaks later on, they get it posterior to the lattice. And that becomes difficult to manage. There's loss of scarring. Sometimes the tears are posterior, so they are difficult to buckle, especially in young patients where you want to buckle. I feel it just complicates things. And I would really like educate patients about risk factors and just examine them every now and again. That's what I tend to do.
Okay, so that was a good discussion, real good discussion on the topic. And if Dr. Mudit is again back with us, I wanted to ask him about his experience with the use of glue in such cases. Like he has been using glue for retinopexy.
Yeah, but I have not had a chance, honestly. Thank you so much. I have not actually had a chance of using fibrin glue in detachments with myopic eyes. The ones which usually have come to us are the ones most of the times which have got more PVR changes, or there's a posterior post staphyloma. So I haven't used it in myopic eyes. One of my colleagues has actually used it in one of the RDs where there was a hole just at the edge of the staphyloma.
Okay.
And that case actually is doing well till now. Brijesh, one of my colleagues, Dr. Brijesh Thakkar did it, I presume, but I have not done it till now.
Okay.
But theoretically, as in all other concepts, it should probably work if it's a detachment with a posterior break and not very anterior breaks or with no significant PVR. Ideally, it should also work well. But to be honest, I have not had a chance to try it out till now.
Okay, sir. Dinesh sir, like there has been a recent surge in refractive procedures, and what I find is most of the times they are told that they are now like fine to no, there's no need for any regular follow-up, and they are like they have been treated for forever. And we often see cases of like post-LASIK patients who never had any retina checkup for 5 years, 6 years, and then suddenly come with retinal detachment. So, do you suggest like we need to sensitize our colleagues who perform refractive surgery that they do need to somehow train or guide their patients to get regular eye checkups done every year?
I'm sorry.
And does it have medical legal implications too if such a thing is not mentioned?
One second, one second. Yeah, hello.
Yes, sir.
Yeah, I have finally gone to the mobile after getting fed up with the phone. Yeah, so I'm sorry, you were asking.
Yeah,
Hello.
should I repeat my
Yeah,
question,
could
sir?
you repeat your question, please?
Yeah. So my question is, sir, that often we find refractive surgeons not instructing their patients to get yearly detailed retina evaluation done. And do you think we need to sensitize them to really make sure that if patients undergo SMILE, phakic IOL, LASIK, that it is compulsory for them to somehow mention and advise in the post-operative notes that patients require a yearly retina evaluation throughout their life? Because we are coming
Yes.
across cases who were never told post-LASIK that they need a retina checkup, and after 5 years, 6 years, they develop detachment.
Yeah, so actually, in at our center, all patients who go for a refractive surgery go for a retina checkup. So they are automatically told that they do need a retina checkup at that time, and then they should be having regular retina checkups in the future. And if they have any procedure, like if it's been lasered or anything has been done, then anyway, automatically they are told that they need a regular checkup. I think see, it's very important that from our point of view, we sensitize our patients to the fact that this refractive surgery, what happens is they feel refractive surgery means अब मैंने myopia ठीक करवा दिया. So
Exactly.
now I don't need any problem. I can't get any problem. So they have to be told that this only took care of. This is like removing the glasses. All you did was remove the glasses, but the retina is the same as it was. So that part has to be highlighted to them.
Yes, sir. And phakic IOL, like when we do a vitrectomy in cases with phakic IOL, do you go for any, do you have any special tips and tricks for such cases, or you find them as good as any routine vitrectomy?
No, see, so there, so there are blind spots. What it needs is patience, and so you spend enough time to go, and then of course, at the same time, you want to be sure that you don't go and touch the lens. So here it's even more important that you don't touch the lens. So you be careful. Usually in high myopes, you are able to get away with a fairly peripheral vitrectomy without touching the lens, but you have to be careful here, because otherwise what you were trying to prevent will happen immediately. Within a month, you will be back with the ICL out and the PCL in.
Okay, okay.
I think
Yes.
my one message really is have patience. I somehow feel people are in a very, people are trying to show that they can do surgery very fast. And, we used to try to show surgery could be done very fast in 1700s, because there was no anesthesia, You had to remove the limb in the shortest possible time, and made a lot of difference. Now with anesthesia, that's not a criteria for how good you are as a surgeon. So the important thing is safety. The important thing is meticulousness. The important thing is to make sure that you do it without causing iatrogenic problems.
Dhanashree ma'am, like often patients who come for LASIK, they are in hurry. They want that, I want to get it done within 7 days, and then I have my wedding scheduled next month. So what is the safe margin you suggest if there's a break and a barrage laser has been done? So what is the safe margin before the patient can undergo any procedure?
So, see, we have a lot of these patients in our institute who come for this LASIK, and we have very, well organized, or we have this preferred practice pattern, and we have these set rules. So, all these patients who come for refractive surgery, they undergo a detailed, dilated fundus examination. And if they are detected to have any peripheral lesions, and if laser is advised, then the laser is done, and they are told to wait for 2 weeks. So 2 weeks is the time which is considered safe for the laser adhesion to occur, and thereafter they are advised to undergo the procedure, because often these LASIK procedure and all, they use this high suction and all, which is a little bit dangerous. So if there are any other procedures like this epiLASIK or whatever, where the suction is not being used, maybe you can allow the patient to undergo that kind of a refractive procedure. But where the suction is being used, I think better to wait for 2 weeks and allow the laser adhesion to occur.
I think the important thing to remember is that when you do a laser, for the first 5 days, the retina is weaker than before. It's not even as good as what it was before the treatment. So he's actually, if guy says मेरे को 2 दिन के बाद करवाना है, it's better he goes and gets it done. Then you can do the LASIK later on, the laser later on.
Okay.
But if you are getting the laser done, then 2 weeks is my cutoff also for wanting for allowing a LASIK procedure to be done. And since you don't know whether LASIK करवा रहा है कि कुछ और करवा रहा है, तो I won't take a chance saying कि ये epiLASIK है तो ये कर लो और ये है तो ये कर लो, से तुम 2 हफ्ते के बाद करवाओ.
Yes, yes. Dr. Ahmed, are you there? So do you have any experience with use of methotrexate to avoid recurrent RD in cases with PVR, like a case with high myopia with PVR? I think
I can tell you there are 2 studies, one from Chitrakoot, in which I was involved, where they did find that the PVR goes down. And there's one from Arvind,
yes,
where also they have said something similar. The only thing is that you have to regularly give them injections, and whether that is post-op patients are very sensitive to getting more procedures done. So you have to balance out the 2 things. And I would say that in one way to bring down this incidence of PVR is first you make sure you do a meticulous surgery. If you do a meticulous surgery, the chances of PVR comes down anyway. The second important thing is you see those patients who have a hazy vitreous before surgery. These are the patients who are more liable to have a problem. Here, I would put them on high dose steroids for some time, 60 to 80 milligrams a day, and then put them on a tapering dose. That brings down the risk also. Methotrexate works, but the point is you have to then tell the patient beforehand that, look, this is what you will be doing to bring down the risk.
Okay.
And also you have to take into account the toxicity of methotrexate.
Yes, that seems a point. Like in studies, trials, they have shown like weekly injections till 13 weeks till SOR is done. And the recent study from Arvind Group, they have just injected it monthly, like one injection every month. And they've also shown pretty good result with that. Like the incidence in they see PVRC 12, the incidence of recurrence had decreased. So maybe that is something for which more evidence is needed over a period of time. So Mahesh sir, anything you would like to add before we close the session?
Nothing in specific. Okay. It's been a wonderful discussion as well as a great lecture. Nothing specific.
Okay. Dr. Shishir and Dr. Kaushik, Mudit sir, anything else?
No, nothing. Thank you. Great discussion and a lot of learning points. Thank you so much, everyone. Thanks, sir. Thanks, everyone.
It was a great discussion, and we had a lot of learning. Thank you, everyone.
So Dr. Kaushik, I think you can let us know about the upcoming webinars. I must say that Dr. Kaushik, Atul sir, and the entire academic cell of ASG, they have been working hard, and they are coming up with even more such masterclass. So can you please tell us a little more about the upcoming classes, Dr. Kaushik?
So we have two more classes on November and December. So there is a class on OCT biomarkers in posterior segment disorders by Dr. Mona Bhinde ma'am, and one on inherited retinal diseases by Dr. Omar Maharu. So also these videos are like posted in our channel. We were lucky to have Mahesh sir and Avinash sir, Pramod sir, Dr. Ahmed Salam has also been our speaker. So these videos are uploaded in our YouTube channel. So I'll encourage you to please visit those. And thank you. Thanks to all the panelists and Dr. Jayant and Dr. Shishir for helping us with this webinar. And I sincerely thank Dr. Atul and Dr. Mayank and Dr. Ganesh for supporting us always. Thank you.
All right. Good night, everyone. Thank you so much.
Yeah, thank you all. Bye bye.
Thank you.
Good day.
Thank you very much. Very nice discussion. Thank you.
Thank you once again, Dinesh sir.
Thank
Good
you.
night, everyone. Good night.
Good night.
Bye. Good night.